Non-traumatic cardiac arrest. Number 8031.26. Protocol. A. High-quality cardiopulmonary resuscitation, CPR, is fundamental to the management of all cardiac arrest rhythms. Periodic pauses in CPR should be as brief as possible and only as necessary to assess rhythm, shock, VFib/VTAC, and perform a pulse check when an organized rhythm is detected. B. CPR must be performed with a chest compression, airway breathing sequence, CAB, to emphasize the importance of maintaining blood flow with good compressions. C. Performing CPR while a defibrillator is readied for use is strongly recommended for all patients in cardiac arrest. D. Advanced airway placement shall be confirmed with EtCO2 detection device or waveform capnography. E. Vascular access, drug delivery, and advanced airway placement should not cause significant interruptions in chest compressions or delay defibrillation. F. Treatment on scene, movement of a patient may interrupt CPR or prevent adequate depth and rate compressions. Consider resuscitative efforts on scene to maximize chances of return of spontaneous circulation, ROSC. Patients in persistent refractory VFib or VTAC at 15 minutes should be transported to the closest receiving facility. Note: consider changing the vector of defibrillation by changing the pad placement from anterolateral to anteroposterior, or vice versa. H. Whenever possible, or whenever feasible and safe to do so, transport the medical durable power of attorney, DPOA, or immediate family member with the patient to the hospital. DPOA and immediate family members can provide medical insight and consent for special therapies or termination of resuscitation to hospital staff. I. Perform an early pre-alert notification to the receiving hospital. Post-resuscitation considerations. A. Any patient with a shockable rhythm, VFib or VTAC, or shocked by an AED at any time who has a ROSC during any part of the resuscitation and who is transported shall be transported to a STEMI center. 1. Any other cardiac arrest patient who is transported shall be transported to the time closest hospital. B. Intravenous, IV, or interosseous, IO fluids should be placed at to keep open, TKO, unless hypotension is present. C. Post-ROSC care bundle. 1. ROSC obtained. A. Manage airway. Early placement of supraglottic airway or endotracheal tube. B. Manage respiratory parameters, SpO2 92 to 98%, in-tidal CO2 measurement between 35 and 45 millimeters of mercury. Initial respiratory rate of 10 per minute. C. Manage hypotension shock with the goal of systolic blood pressure, SBP, greater than or equal to 90. Normal saline, 1,000 milliliter bolus, and concurrent push dose epinephrine, 0.01 milligrams per milliliter, which is 10 mics per mil. Dose is 0.5 to 2 milliliters every 2 to 5 minutes, which is 5 to 20 micrograms. Okay. Titrate to SBP greater than or equal to 90. Reassess vital signs after each bolus. D. Obtain a 12-lead ECG approximately 7 minutes post-ROSC. E. Remain on scene for approximately 10 minutes for post-ROSC care to optimize parameters listed in A through D. Evaluate and treat for reversible causes for arrest, H's and T's. Bradycardia, refer to PD number 8024 cardiac dysrhythmias. Congestive heart failure / pulmonary edema, refer to PD number 8026, respiratory distress. Termination of resuscitation considerations. A. Consider termination of resuscitation efforts after 20 minutes of advanced life support ALS care if both of the following are present. 1. Pulseless apneic or agonal respirations with no signs of life. Non-reactive pupils, no response to pain, no spontaneous movement. 2. Asystole or wide complex pulseless electrical activity with a heart rate of less than 40 beats per minute. Now the flow chart. CPR quality: push hard, greater than or equal to 2 inches, and fast, greater than or equal to 100 per minute, and allow complete chest recoil. Minimize interruptions in compressions. Avoid excessive ventilation. Rotate compressor every 2 minutes. If no advanced airway, 30:2 compression ventilation ratio. Quantitative waveform capnography. If PETCO2 is less than 10, attempt to improve CPR quality. Return of spontaneous circulation, ROSC. Pulse and blood pressure. Abrupt sustained increase in PETCO2, typically greater or equal to 40. Shock energy. Biphasic. Manufacturer recommendation, example would be initial dose of 120 to 200 joules. If unknown, use maximum available. Second and subsequent doses should be equivalent, and higher doses may be considered. Monophasic, 360 joules. Drug therapy. Epinephrine, IVIO dose, 1 milligram every 3 to 5 minutes, up to a total of 3 milligrams. Amiodarone, IV or IO dose. First dose, 300 milligram bolus. Second dose, 150 milligrams. Advanced airway. Supraglottic advanced airway. Waveform capnography to confirm and monitor placement. 8 to 10 breaths per minute with continuous chest compressions. Reversible causes. H's: hypovolemia, hypoxia, hydrogen ion acidosis, hyperkalemia, hypothermia. T's: tension pneumothorax, tamponade cardiac, toxins, thrombosis pulmonary, thrombosis coronary. Number 1, start CPR. Give oxygen, attach monitor / defibrillator. Rhythm shockable. We're going to go to the yes side first. Yes. Number 2, V-fib or VTAC. Number 3, shock. Number 4, CPR 2 minutes, intravenous IV or interosseous IO access. Rhythm shockable. Shock. Number 5 is shock. Number 6, CPR 2 minutes, epinephrine every 3 to 5 minutes. Consider advanced airway capnography. Shockable rhythm. 7, shock. 8, CPR 2 minutes, amiodarone. That would be the 300. Treat reversible causes. Then it goes back up to rhythm shockable, and then you go to 5, shock. CPR 2 minutes, epinephrine every 3 to 5 minutes. Consider advanced airway capnography. Rhythm shockable. Shock. 7 is shock. 8, CPR 2 minutes, and then you'd give amiodarone 150. Treat reversible causes, then you'd go back up to 5 until you reach the max dose of 3 milligrams of epinephrine. At any time, if the answer to the question rhythm shockable is no, then you go down to, if considering termination of resuscitation, go to termination of resuscitation considerations. If ROSC, go to post-ROSC care bundle. Now we go back up to after you start CPR at the beginning with 1. If the answer to rhythm shockable is no, then you go to 9. That's asystole or PEA. Number 10 would be CPR for 2 minutes, IV/IO access, epinephrine every 3 to 5 minutes. Consider advanced airway capnography. Rhythm shockable? Question again? No. CPR 2 minutes. Treat reversible causes. Rhythm shockable? no, then you go to consider termination in that box. Or if you get ROSC, you go to that. So if you ever have in one of these on this side, rhythm shockable, and it's yes, then you go to 5 or 7, which is shock, right? And then give epi or amiodarone. And that is the end of non-traumatic cardiac arrest.